Hello and good afternoon, everybody. My name is Garrett Schmidt, and I am the managing editor for BBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Calcium Health. And it is titled Empowering Your Most Challenging Hypertensive Patients, a new engagement framework for value-based care providers. And I'm excited to hear the presentation today. I think there's going to be a lot of great takeaways, and it's definitely an important issue. So a few items of note before we get started here. Everyone is joined in listen-only mode, so you don't need to worry about muting your microphone or your camera or anything. That's been done for you. Also, I wanted to let you know that during the webinar, we definitely want to hear from you. So we're going to have a Q&A section at the end, but there might also be some times we take them during. So go ahead and ask your question if at any point. If you have a question that you would like to ask our speaker, go ahead and do that at any time. And the way you do that is using your control module. There's a little questions area. So it's not the chat, it's actually little questions, and you can put it there, and then we'll be able to get to as many of them as we can today in the allotted time. If we don't get to yours, we'll make sure to get to you via email afterwards. So you go ahead and ask your question. Also, today's webinar is being recorded. So we would love to have you review it later and share it with colleagues and whatnot. So when we're done, what I'm going to do is send you, everyone who's registered, I'll send a link to the recording as well as where you can download the slides, and so that you'll be able to have those and follow along as well. So without further ado, I wanted to introduce our presenter today, Cathy Kenworthy, who's the founder and CEO of Health Hippo, as well as the president of Conceivabilities. And then Jen Adamski is there as well. You can see her, and she's going to be helping us during the Q&A section. So at this time, I'm going to pass it over to Cathy. Welcome.
Garrett, thanks so much. And it's so such a privilege to be here today to talk to your membership about this bedeviling problem of hypertension. So briefly, just some background on me. I founded a company called Health Hippo, which I built to try to solve the problem of inequities in information. How can patients have more practical and more specific and frankly more accurate information as they are making decisions about their health? I'm also president of a company called Conceivabilities that works with families that are trying to build their family but need the help of a surrogate or an egg donor to do so. So that's been a tremendously exciting opportunity. You can see some of the other things that I'm involved with in terms of board membership and some of my educational background. Two items that are not on here that I wanted to highlight. One, I was a member of the board of the American Heart Association here in Chicago for many, many years, and that informs some of my perspective today on hypertension. And secondly, I'm a fellow with the Aspen Institute, specifically the Health Innovator Fellowship, which also has given me a lot of perspective on what I'll speak about today. So enough about me. If we dive in to our first slide, this bedeviling topic of hypertension, which I believe was, believe it or not, first described in 1733. So it's been around for a long, long time. It's probably based on the science, one of the most well understood issues. However, this issue and this metaphor for patient engagement and patient empowerment is one that I think we really can understand and see play out with regard to hypertension. I personally think of the term as patient engagement as something that we might do at somebody. Potentially an even more unhelpful term that's not on this page that I hear a lot is a term called compliance. One person is going to tell another person what to do and expect them to be compliant with it. And we know that can be very difficult to get adults to respond to behavior change in that way. So I'm going to talk today about something that's on the right side of this page around patient empowerment, and really taking hold of something that's been talked about in healthcare for so many years of consumerism and consumers being shared decision makers and consumers being participants in their health issues, specifically as we think about hypertension. We know hypertension in particular requires behavioral and social change as much as it requires science. And so can we bring to life a different way of thinking about that even with our most challenging hypertensive patients? So moving forward to the next slide. By the data, one would have to say that we have a real problem around hypertension, and perhaps even use the adjective that it is out of control. So we can see here trend data going back decades. While there has been some progress with regard to, kind of the middle portion of this time period, we know that the trend is not our friend. As I mentioned, this is one of the areas of medical science where there's perhaps the most widespread consensus with this very well described problem of how to manage, control, treat, even possibly prevent hypertension. Yet that is not the experience, and by some estimates, perhaps half of the individuals shown on our chart on the right are termed to be out of control. So if we move forward to the next slide. I'm here to share a proposition that perhaps communication is the issue that sits at the heart of this problem. On the one hand, we've got patients who may think that they understand hypertension and their hypertension when they really don't, and equally we may have providers who think they understand what's best for patient, and that patient may or may not agree. So on the patient side, this is perhaps familiar ground. I know through my work with the American Heart Association, the levels of anxiety that have been associated with the diagnosis of a hypertension situation. People will say, well, gosh, I just ran up the stairs that one time and my blood pressure was a little high. Or maybe it was just this one thing or another thing, very anecdotal, and sometimes even worse, kind of a sense of the person being diagnosed with hypertension has potentially done something wrong, has brought it on themselves, because we sometimes describe this as a lifestyle disease. So those kinds of issues are going on with patients. On the provider side, equally, they may think, and participants in the call today may think they know what's best for their patients, but with perhaps not a real reckoning of understanding what is it that's an opportunity for that patient in the context of the constraints within their life? What are some of their family and living situations that could weigh upon their ability to undertake certain kinds of strategies with regard to managing of hypertension? And so there really may be dissonance on both sides of the patient-provider relationship when it comes to hypertension. Fear not, though, I've got a framework that I want to present as a way that we might solve some of this. So the idea of a shared decision framework really comes from the idea of doing good teaching and good educating, which we know is not educating at people, but it's by involving somebody in the quest for knowledge. And that starts with really grounding somebody in the diagnosis of hypertension. Measurement, we know, is important to hypertension and many other chronic conditions. So we're going to talk a bit about measurement. Really wrapping an understanding of risk factors, how at risk is a particular individual, and engaging somebody in that conversation. And then 1, 2, and 3 leading to 4, which is treatment, versus starting with 4, assuming 1, assuming 2, and assuming 3. We're going to present an alternative here, which is to really step somebody through in a very methodical way each component of this. So if we move forward one slide, some of the questions that could be explored as part of diagnosis is, what does it mean to have hypertension? I'm sure that the people assembled on today's call know things like, one of the things it might mean is that even everyday care that one might need, an emergency appendectomy, something which seems to have no bearing or relationship on hypertension, treatment for that appendectomy could be forestalled or even not possible based on somebody's hypertensive status. So, the meaning of hypertension, of course, also has long-term ramifications on the functions of major organs, heart, kidney, brain, all of that. But it could also have very practical implications as I mentioned with appendectomy, with regard to elective surgeries, and many other topics could be at play. Second, is having hypertension the patient's fault? And I think this is something where we need to be very thoughtful as we think about engaging particularly that challenging population, where the more somebody feels like they're culpable, and maybe we might look at this situation through a certain lens and think that they are culpable, we need to understand that putting somebody on the defensive is probably going to shut down some of those learning and educational items. And then, as I say, the practical ramifications of unmanaged blood pressure for the patient's care. Now, as we go through each step of this framework, I'm going to share some additional tools that have been developed to help implement this framework. And this is intended to be kind of a self-assessment tool. And so the first of those questions is understanding the risks associated with hypertension, particularly with regard to this diagnosis. So I have a parent or a close relative with hypertension, and I'm 55 years or older. That would be potentially one level of risk. I have a patient or a close relative with hypertension, but I'm younger than 55 years old. That would have a different ramification. And then C, I do not have a parent or a close relative with hypertension, and I'm younger than 55 years old. So you can see our language here is very accessible. Our language here is very clear and can lead to conversation about, gosh, when we look at your diagnosis of hypertension, imagining myself as a provider speaking with the patient, and some information on this self-assessment, that creating a framework and an opportunity for a different kind of conversation about somebody's diagnosis. So moving from diagnosis to our next step, measurement. I'm going to talk about measurement here with regard to blood pressure, but also measurement of other lifestyle factors. So, for some reason with regard to blood pressure, we have many times relegated blood pressure to something that happens within the four walls of a provider's office. Recent studies show quite conclusively that self-assessment of blood pressure is one of the most important steps that we can take. In fact, self-assessment of blood pressure is viewed to be more accurate than blood pressure within the four walls of a physician's office because of things like white coat phenomenon, and the reverse. People can have blood pressure that's too high or too low in their provider office versus having comfort in their own home and in many other settings of what somebody's blood pressure might be. There are automated cuffs, and I know there's been a lot of debate over the years in terms of manual measurement versus automated measurement. I think the field has progressed quite a bit, and there's a lot of good to the automated cuff system that has been validated through numerous studies. And I present all this with some curiosity about the fact that, it used to be, and if we could stay on the prior slide, it used to be the case that, people would measure, Fitbits and steps and glasses of water and all kinds of other information that can be helpful. Hopefully we all know how to step on a scale and measure our weight. But we've not yet gotten comfortable in saying we should all be able to measure our blood pressure, and we've got the tools and the know-how to be able to do it. So that's a very important part of this framework that I wanted to just kind of pause on and really identify. So if we move forward and consider this self-administered risk assessment tool that I just mentioned, again, asking questions in this way that are more neutral and allow patients to engage in this conversation around measurement, starting with things like everyday habits of eating, drinking, activity levels, weight, and getting individuals to kind of reckon with, hey, where are we? Truth be told, I'm overweight, I eat out frequently, I have a taste for salty and sugary foods, etc. Boy, I could stand to make some changes. Option B, while I could stand to lose some weight, improve my eating and drinking habits, and be more active, I have a reasonably healthy lifestyle. That could be a source of interaction with a patient and a provider. Or C, I'm really quite disciplined about my eating and drinking habits as well as my activity levels, and it shows. So again, this being a way to kind of warm up the topic of measurement and warming up things that are sort of familiar ground within our life, but then taking this towards hey, how might somebody play a role in measuring their blood pressure? Okay, so we've got diagnosis, we've got measurement. We'll move on to item 3, which is risk factors. Risk factors are, of course, known maybe to us as providers, but this again is about making those risk factors visible to the individual. How do risk factors impact the intensity of the treatment plan? And what else is going on in somebody's life in terms of childhood expectations, current family norms, pressures around the consumption of certain kinds of foods, be that ethnic, perhaps use of alcohol, other kinds of things. Are there other risk items in the individual's life that need to be attended to or certainly thought about in the context of a rigorous treatment plan? So some examples of that, if we move forward to the next slide, in our self-assessment tool, include, jumping into the way back machine. Let's think about your childhood risk factors and how that might play into adult hypertension. Perhaps the individual, even as a child, had instances of high blood pressure, answer A. Answer B, some individual who had early labor and early delivery and arrived a little early or arrived low weight. We know those are risk factors with regard to experiencing adult hypertension, or somebody who had none of those factors. And really, this is their first not only instance of hypertension, but had a 40-week normal weight delivery. Item 4, more sensitive ground. There are substances that can cause blood pressure to be elevated. We know what they are, and we have half a dozen of those listed here. And again, an opportunity for a kind of no judgment assessment by the patient. How many of these do we use? 3, 1, 2, none. And having an opportunity for some interaction around how use of these items might and intention with regard to use of these items could play into a treatment plan. Okay, so we've got 2 questions there. We've got now diagnosis, measurement, understanding additional risk factors. So now we're prepared, and let's talk more about treatment. So I think the first idea that I would offer is the idea of having an explicit, realistic, shared goal for managing hypertension, which might mean several things. It might mean something about the actual value of the blood pressure that's being targeted. It might mean time frame, over what time frame might that goal be achieved. And it might involve qualitative factors like side effects associated with medication or other cost parameters or other things. And so really using the good work of items 1, 2, and 3 in this framework to have truly an explicit conversation between provider and patient around what is a viable goal. Maybe there's some negotiation that needs to take place around that goal, but having one that really is shared that both parties can continue to come back to and monitor. And then related to that goal, airing out kind of the full range of pharma and non-pharma options associated with managing of the hypertension. There's great tools from the American Medical Association, the American Heart Association of losing X amount of weight or restricting certain amounts of sodium or have actually been quantified in terms of the level of impact on blood pressure and our options depending on the risk factors and some of the other things that we've learned potentially in weighing and evaluating both pharmacological and non-pharmacological interventions. So if we move forward one slide, an opportunity for self-assessment and reflection here may include a question like, many studies have shown, or a statement, many studies have shown that how you think about using prescription medication is an important variable in really surfacing early on an individual having an opportunity to state, item A, I have real concerns. I'm not convinced that prescription medicine is important for treating hypertension, that it will help me, or that I can afford it. And if somebody feels that way, it sure is important to surface that early and something that can actually be a topic of problem solving and negotiating as a shared goal is set. Item B, I am uncertain about whether prescription medicine is important for treating my hypertension, whether it can help me, whether I can afford it. So some ambiguity that potentially can be further informed and shaped. Or item C, if prescription medicine is part of treating managing my blood pressure, no problem. I think it'll be important. It can help me. I'm not worried about whether it's going to cost me some money, right? And we know that patients will have a wide spectrum of beliefs on items A, B, and C. So if we move forward to our next slide, you know, this proposition is that the context of item 1, a full understanding of diagnosis or even diagnoses if there's more than one thing going on for that individual. Measurement, patients being fully empowered to measure their blood pressure and measure other things going on in their life. Risk factors and treatment together yield empowerment. So let me pause there. Jen, maybe there's a question that's come through. Jen, you're muted.
Thanks, Kathy. Sorry about that. We received a question about the measurement piece. All this measurement data is great, but how do we handle this influx of large volumes of data?
So Jen, that's a great question, and I think there are tools that are available to providers. You know, a big part of this proposition is the patient having mastery themselves of that data, in addition to being able to share that with provider. I think we'll be covering some other items a little later in the presentation to give a little bit of a teaser on what some of those other tools might be like to manage some of that data. So great question, thank you for that.
Thank you.
Okay, so here's a framework. Hold it up to the light of day. Hopefully we'll have some debate about that. But if we think about, boy, how might we start to implement a framework like this? You know, I do think of this very much as a educational topic and really democratizing the information and having clarity about, even with hypertension, there's things that the medical field knows. There's things that the medical field really doesn't know. Why is it that an individual has developed hypertension at a particular point in time? That may not be something that's known, and having candor around that. What do we know? What do we not know as a framework for educating diagnosis, measurement, hypertension, and then treatment? Within that, and I think as you heard me say, there are important decision points around really coming to terms with the shared goals and priorities for the treatment path. Are the goals realistic and specific in the context of that patient's life? Is it something that that individual sees being able to accomplish for themselves? Are there decision points about how frequently somebody's going to measure their blood pressure, and how, to the question Jen shared, how might that information be shared on a consistent basis in a way that the provider can ingest? Being aware of changes in risk factors as somebody gets older, as somebody is using different kinds of substances in their life or not, different kinds of health issues. And then finally, being dynamic and prioritizing and planning for changes in the treatment path. Jen, back to you, more questions.
Great, Wally had a great question. If we could go back to that prior slide around, I think, the goals piece, but specifically the question was, how do you measure your program success and what is your national success rate?
Great question. And did you want to go back, Jen, to one of the slides?
This is the one I think we're talking about goals, but looking at the goals from a broader kind of program perspective.
Perfect. Yeah, I mean, I think it's a fair question in terms of, you know, what if the patient's goal is different than the sort of prescribed goal of the you know, what the protocol would say that somebody should achieve. And, you know, I think we can hopefully have the capacity to understand that there might be real differences between those goals, that achieving, let's say, a lesser goal, but achieving it successfully and with empowerment and with collaboration sets the table for continuing to up the bar. Obviously, the American Medical Association and the American Heart Association have both set, you know, very, very stringent goals, even going all the way into the pre-hypertensive phases. That may not be realistic, but I would argue on the other side, having, you know, a high bar and let's say half of the patient population nowhere near that, and very challenging, even in the name of today's presentation, that's not great patient care either. So hopefully we can identify and have capacity for goals that point us in the right direction and allow set the table for further progress as we keep going, but doing it in a way where people are part of that journey. So great question.
Thank you, Cathy.
Thanks, Jen. Okay, so if we think and take a step back, I'm sympathetic to the idea that this may sound like a tall undertaking. There is a set of technical demands, as was implied by one of the questions, around diagnosis, having a platform that can serve as a basis of on-demand learning with a newly diagnosed hypertensive individual, having a measurement protocol where that measurement data can be useful and shared, and having triggers with regard to knowledge and training, how to use an automated blood pressure cuff that somebody could cue on demand. Risk factors, changes in somebody's situation. People have hypertension for their life, and there will be changes over the context of somebody's life. And so having automated triggers around what's happening with the underlying risk factors and allowing those to be part of the journey. And then finally, treatment, having guided pathways where somebody has some reminders. Gosh, it's been a little too long since you've measured your blood pressure. It's been, you know, daily check-ins if pharmaceutical options are part of the treatment path. All of these, you know, congratulations, we appear to be achieving the goal, right? There's ways that technology can play into each component of this that I think we can all imagine. And then staff, you know, really embracing the idea that this requires an investment of staff time that needs to be planned for, that needs to be part of this. This isn't just, you know, kind of going to happen without that allocation of time. But I do believe that this is a protocol which, you know, some of that upfront investment can create a lot of efficiencies downstream, so that there's a thoughtful approach to tracking and monitoring, and not just episodic emergency-based interaction, which puts a lot of pressure on practices. So with that, I actually want to turn it to Jen and ask her for some thoughts around how might calcium be a helpful partner with regard to undertaking this kind of framework.
Definitely. Thank you, Cathy, by the way, and one of the earlier questions around, you know, what do you do with all of this data? Being able to have that 360-degree view of your patient, it can be incredibly valuable, where you're walking with them along the way. You know, I've seen cases where, you know, you get the patients know, or they maybe want to be compliant, but they get the sheet of paper at home, or the stack of paper of instructions, and it gets buried under a desk. But here it's real time, it's in front of their face, and it's also, you know, there's this gamification aspect of it where folks are able to interact and take control, and what we say is think healthier about their health. So, you know, connecting their devices to, you know, monitor all of the observations, their medication management, all of these things. I mean, hypertension is such a complex kind of myriad of things that you need to recall to take care of yourself or your loved one. And as a patient, to be able to have all of that in one place already in the palm of your hand is incredibly convenient. But as a provider as well, being able to get those alerts and those, you know, notifications of who to follow up with, to your point about the staff time, Cathy, being able to save that staff time and focus on the patients with the most need, or the most most urgent needs, can prove to be a huge time saver, but also help improve outcomes in the long run. If we could go to the next slide, just to revisit the framework to apply that. So as I mentioned, you know, being able to get that diagnosis, have this library of information rather than just, you know, the paper handouts. There's so much great material there, but to be able to have that library available readily. And then also the measurement piece. So step 2, as Cathy spoke to, with the prompt to take your vitals, or to, you know, have your vitals sync up. The devices that are integrated. So, you know, getting that daily measurement, even just being more aware of the fact that that's being measured, helps folks kind of make healthier choices throughout the day. The gamified piece, again, we've seen a number of people just enjoy. Some folks are very competitive. They want to compete with themselves. They want to compete with friends or family, and to be able to see your name up on the leaderboard, seeing your health index score, grow or improve, is all motivation, and playing back to the behavioral science piece that an app can provide, getting those prompts and reminders for risk management. And then finally, for that fourth step around the treatment piece and getting those pathways configured based on goals, as we spoke about earlier, and that dashboard for the provider piece, giving providers that real-time insight, that 360 view throughout this whole process, actually, is key to all of this. And I think I might even just segue to one of the questions we have about this framework, Cathy, if you're great with that. We've had some great questions this session. One of the questions was about the framework. If we could go back to this framework slide, the question was, is this a cyclical framework? Do we go back and make changes or revisit as we get more feedback from patients?
Very thoughtful question. And I think the answer is absolutely, right? An individual will have hypertension to one degree or another once they've kind of crossed over into that diagnosis for their life, with age, with progression, with the presentation of other health issues, with their own success or not in terms of adapting to some of these treatment protocols. There will absolutely be changes. Somebody's blood pressure could become too low, somebody's blood pressure, right? So I absolutely think thinking of this as a cyclical concept is very important, and I think it's why having the right technical platform sitting as the chassis for this is very helpful, so that one can identify those changes and be prepared to kind of restart and say, boy, we're at a moment we need to catch our breath and reconsider the diagnosis and the scope that we're working with.
That was a great question and great answer, Cathy. Thank you. I'll segue to a couple other questions we received, and I'll just remind the audience, if you have any questions, to feel free to use the question module, bottom right corner of your screen, and I'll be watching those as we get through. We have a couple more questions that came in, so feel free to share those in the meantime. Cathy, the other question around staff time, when we were speaking about that, what type of staff training would be involved in transitioning to this model?
Yeah, I think that's a terrific question, and I would like many things, right, the scope of this could be quite varied based on the objectives. Do you have a practice with a tremendous amount of burden associated with these very challenging hypertensive patients? Where is this in terms of your own priorities for your practice as we make transition to value-based care? How far away are you from where you need to be in terms of management of your patient population? And if you anticipate that you've got quite a large gap between where you are today and where you want to be, I would recommend quite an intensive training approach. At the other end, you might be a practice where you've got momentum with components of your patient population, but there's a targeted population that you really haven't been able to get to, and maybe you could do something that's more targeted. Regardless of which end you were to consider, I think the core notion of this is the idea of asking open-ended, non-judgmental, true questions, i.e. questions where you don't yet know the answer, and having some skill and comfort with eliciting answers to those questions, and creating a strong context among your care providers, nurses, PAs, others that might be working with these patients, even receptionists who are receiving phone calls, that is empathetic, compassionate, and interested in discovering new answers with regard to how to help people get from where they are today to where they need to be.
That's a good segue. Another question, we've got a couple more that had come in. One, talking about patients. What do you do with patients who don't want to take ownership of their treatment and just want someone to tell them what to do?
Sure. Well, I would say that that too, of course, is an important patient population, and I would just wonder, if it's as easy as telling that patient, well, here's this medication and just take this medication. How prevalent are those in the 50% of the bucket that are not in compliance? And is it possible that some patients say, I just want somebody to tell me what to do, but truth be told, the idea of understanding why they're taking that medication and having some framework around that maybe is in fact instrumental and important. Having said that, I feel like even the assessment tool that we shared here today and kind of broke apart into the framework would be, take somebody less than a minute probably to engage with those 5 questions, and you'd probably learn something about what's really going on for that individual by their answers to those questions.
One other question around PHI security. So PHI security is very important to many patients. With the availability of zero knowledge proofs, PHI is easily eradicated if aggregated data is made available. To what extent are you aggregating and selling the patient data, I would assume you meant Wally, you obtain for analysis and feedback?
And Jen, I might steer that question directly back to
Exactly. I'm happy to speak to that, Wally. That's a great question. And as far as the data goes, we are definitely, HIPAA compliance security is top of mind with all of us, all of the platform as a whole, and can certainly share out some detailed data around that. But making sure that we're on Azure Secure, the HIPAA, there's the HIPAA kind of step before folks even get into our app, and then also not selling data that is not happening, and definitely PHI is top of mind with calcium. So, and happy to follow up with more detail on that question too, Wally, if you had more. We can connect afterwards. And I think, Cathy, there was one other question, if I may, and then I'll hand it over to Garrett. Last question that we've received, unless anyone would like to send some more, is actually I think we covered all of them. So I guess I will hand it over to Garrett, and thank you everyone for your participation. And Garrett, you'll kind of bring us home here with what we can expect after the webinar.
Sure. Well, thank you very much. And Cathy, that was a wonderful presentation. And I hope everyone got a lot out of it. I know I did. It's such an important issue. And thank you for covering it the way that you did. As we close out here, I wanted to encourage everyone to go and visit the Calcium Health exhibit booth, the virtual exhibit booth at vbcexhibithall.com. And there you can interact with their team and have a bunch of resources at your disposal and really just kind of learn up on what they're doing in the value-based care world. So definitely encourage you to go and see that. There will be a link in the slides when you send that. So yeah, please do that. And then lastly, if you would like to reach out to any of our speakers or the Calcium Health team, please do that. On this last slide here, you'll see Ray Villar, his information there. If you want to reach out to him, he'll be able to put you in touch with whoever you need to, or I'm happy to do that as well if you want to just reach out to me. But I wanted to thank you all so much for coming today. I know there's a lot competing for your attention right now, and we definitely appreciate you spending your afternoon with us. I hope this is a very informative session for you. Thank you so much, and have a wonderful rest of your days.